Dear ladies and gentlemen, thank you for having me. Thank you for the great opportunity. My name is Haider. I'm from Bremerhaven, Germany. I'm a resident in urology, working in a urological medical office. And I'll be talking about effects of long-term testosterone therapy on urinary function and quality of life in men with functional hypogonadism and overweight or obesity in a urological registry study. So, according to current EAU and AUA guidelines, there is no evidence for an increased risk for prostate diseases with testosterone therapy. However, concerns in general as well as urological clinical practice are still common. To provide more data from clinical experience, we updated analysis of a registry database of men with functional hypogonadism, which we had last published in 2018. So a little bit of our materials and methods. It's a urological registry study of men with hypogonadism defined by 2 morning total testosterone levels below 12.1 nanomole per liter. And the study was initiated in 2004 in a single urological office in Germany. After exclusion of men with primary hypogonadism, for instance Klinefelter syndrome or osteotomy following testicular cancer, 779 men were classified as having functional hypogonadism. Of these men, 723, which is about 93%, had overweight or were obese. 267 men received testosterone under cannula injections, 1000 milligram every 12 weeks following an initial 6-week interval, and was labeled as our T group. Whereas 356 men had opted against the testosterone treatment and served as our control group. We are reporting 12-year results, which also were analyzed. Changes over time between groups were compared and adjusted for age, weight, waist circumference, fasting glucose, blood pressure, lipids, and quality of life to account for baseline differences between both groups. So looking at the baseline characteristics, we can see that we have a slightly younger cohort in the testosterone treated men, but looking at the urinary function, we can see that they had a statistically significant higher IPSS and residual bladder volume, and we can also see that the men who were untreated had at baseline better quality of life and a better erectile function. So looking at the changes in IPSS in men with functional hypogonadism and overweight or obesity, we can see that throughout the observation time, the untreated men had a worsening of their IPSS, whereas the men on treatment had an improvement of their urinary function, with a steep decrease of IPSS in the first couple of years, and afterwards it was a steady, sustained decrease, resulting in an estimated adjusted difference between both groups at 12 years of 9.7 points of IPSS. Looking at the changes in residual bladder volume in these men, we can see what we expect in aging males. They had an increase in their residual bladder volume when they were untreated. However, the men who were on treatment had a steep decrease for the first couple of years, and afterwards were able to sustain this decrease with a more steady decrease, resulting in an estimated adjusted difference between both groups at 12 years of about 85 milliliters. So let's look at the changes in prostate volume. We can see that both groups had an increase in prostate volume, with a slight difference after 12 years of 0.52 milliliters, but this however, being statistically significant, it's clinically irrelevant. Looking at the changes in the aging male symptom score, we can see that the quality of life in men who were not on treatment was worsening also throughout the observation time. However, men on treatment had an increase in quality of life during the first 2 years, a steep decrease of the AMS, and afterwards were able to sustain this decrease or improvement of quality in life, resulting in an estimated adjusted difference between groups at 12 years of 51.4 points in their AMS score. So let's take a look at the erectile function. What we expect in aging males is that their erectile functions decreases or worsens, and this is also what we can see in this untreated man. However, the treated man had an increase in their IAF, and in the first couple of years it was a steep increase, and afterwards it was a more sustained, resulting in an estimated adjusted difference between both groups at 12 years of 24.4 points of IAF. So let's remember 24 points would be the difference between no erectile dysfunction and severe erectile dysfunction. So let's take a look at the events. In 16 patients of the control group, we had cases of acute urinary retention. However, none were reported in the testosterone treated group. So for interpretation, while baseline mean IPSS was in the mild to moderate category and there were no patients with severe symptoms, one would expect IPSS to worsen with advancing age. We found this to be the natural development in patients with hypogonadism and overweight or obesity who were not treated with testosterone. However, in those patients who received the long-term treatment, we could show that urinary function measured by IPSS and residual bladder volume improved over time. This seemed to be independent of prostate volume because the age-related increase in prostate volume was not different between the T group and the control group. And to conclude, long-term testosterone therapy in men with functional hypogonadism and overweight or obesity improved urinary function and quality of life, which worsened in untreated controls. Thank you for your attention and looking forward to meeting you in person again someday.